Standard blood pressure guidelines recommend a target below 130/80. And for adults over 60, research published in cardiovascular journals suggests that pushing aggressively toward that number may be doing something far more dangerous than leaving it slightly higher. Not in rare cases. In a pattern cardiologists are increasingly documenting in seniors who did everything right. The target your doctor gave you may not have been designed for the arteries you have today. Here is what almost no one in a clinical setting will say plainly. The landmark trials that established the 130/80 standard were conducted predominantly on middle-aged populations. Adults over 70 were systematically underrepresented. And if you take your medication every morning, check your numbers faithfully, hit that target every single week, and still feel exhausted by noon, dizzy when you stand up, and vaguely wrong in a way you cannot explain to anyone, that is not aging. That is a cardiovascular system being managed by a number that was never calibrated for it. What happens inside aging arteries when blood pressure drops too fast, too far, is something most patients are never told. And that gap in your knowledge may matter more than any pill you are currently taking. My name is Dr. Jennifer Ashton. I am a cardiothoracic surgeon with 26 years of clinical experience treating hypertension and heart disease, specifically in adults over 60. In this video, I am giving you 5 specific findings about standard BP management that apply directly to your heart, your morning routine, and your next doctor's appointment, starting tomorrow. What is genuinely at stake is your independence, your energy, and whether your cardiovascular system is being protected or quietly undermined by the guidance you trust most. The number on your blood pressure target came from somewhere. Most seniors who take their medication every morning, check their readings faithfully, and report back to their doctor with numbers that fall exactly where they were told to aim, have never once been told where that target actually originated. The 130/80 standard that governs blood pressure management for millions of adults over 60 was built primarily on research conducted in middle-aged populations, skewed heavily male, with adults over 70 either underrepresented or excluded entirely. The clinical trials that produce the guidelines your doctor follows today were not designed with your arteries in mind. They were designed for arteries that were younger, more elastic, and operating under entirely different physiological conditions than the ones managing your circulation right now. A garden hose left out through a full summer hardens. The rubber loses its give. Run the same pressure through it that worked fine when it was new, and the stress concentrates differently. At junctions, at bends, at the places where stiffness has replaced flexibility. Aging arterial walls behave in a way that maps directly onto this. After 60, the elastin that gives vessels their recoil diminishes. Calcified deposits accumulate along arterial walls, and the mechanical stress that a given systolic reading places on that tissue becomes fundamentally different from what the same number would mean in a 45-year-old. The reading looks identical. The physical reality inside the vessel is not. This is what I have watched in 26 years of cardiothoracic surgery. The number on the chart and the condition of the tissue on the table do not always tell the same story. A systolic pressure of 120 in an aging cardiovascular system is not the same clinical event as a systolic pressure of 120 in a middle-aged one. And the guidelines your doctor uses to set your target have not always accounted for that difference with the precision your heart deserves. The target number you were given may have no expiration date stamped on it. Your arteries do not have that same luxury. What I am about to walk you through are 5 specific ways that standard blood pressure treatment interacts with aging cardiovascular physiology in ways that most cardiologists never discuss openly with their patients. And the reason this matters is not abstract. At least 3 of these will describe something you have already experienced and quietly accepted as just getting older. Rising from a chair too quickly and feeling the room go briefly dark. That half second where the edges of your vision close in before everything normalizes has become something you probably do not mention anymore. You stand more carefully now. You pause a moment before walking. You have built small compensations around something you assume is simply part of aging past 65. It may not be. In a younger cardiovascular system, the baroreflex, your body's automatic mechanism for adjusting blood pressure in response to postural changes, responds within 1 to 2 seconds of standing. The vessels tighten, pressure redistributes, cerebral blood flow is maintained. After 60, baroreflex sensitivity declines measurably. When a blood pressure medication is actively suppressing your systolic pressure toward 120/80, your baroreflex no longer has the physiological reserve it needs to compensate quickly enough when you shift from sitting to standing. The result is transient cerebral hypoperfusion, a brief, real reduction in blood flow to the brain that produces exactly the sensation you have been attributing to age. Research published in geriatric cardiovascular literature, including work associated with the Journal of the American Geriatric Society, suggests this drop in standing blood pressure affects a significant percentage of seniors on standard antihypertensive regimens, and that it is disproportionately common in those whose BP is being managed to the most aggressive targets. Worth understanding clearly, falls in adults over 65 are not always caused by balance problems or inner ear changes or reduced coordination. A blood pressure medication working exactly as prescribed, hitting exactly the number a doctor ordered, may be the contributing factor that never once gets documented in the chart. This is the most visible harm in the list, and it is only the first. The kidneys present a different kind of paradox, and it is one that almost no one raising your blood pressure medication dose has ever named for you directly. Blood pressure medication is frequently prescribed, at least in part, to protect kidney function. High systolic pressure over time damages the delicate filtration structures inside the kidney, and bringing that pressure down is considered a protective measure. That is the logic. What the logic does not always account for is what happens when blood pressure drops below the level that aging renal vasculature needs to maintain adequate filtration pressure in the first place. Aging kidneys depend on what is called perfusion pressure, sufficient arterial pressure driving blood through the glomerular filtration system to keep it functioning. ACE inhibitors and ARBs, which are medications that work by relaxing blood vessels and reducing the mechanical strain on the heart, lower systemic pressure and also reduce the pressure inside those filtration structures directly. In seniors with already declining nephron mass, the functional filtering units of the kidney naturally reduce in number across a lifetime. This can shift the balance from protection into mild chronic underperfusion. The kidneys are not being damaged dramatically. They are being quietly stressed. Sometimes the only signal is a gradual, incremental rise in creatinine numbers that physicians watch but do not always connect to the aggressiveness of the BP target driving the medication. Research from major cardiovascular nephrology programs, including work from institutions like the Mayo Clinic and Cleveland Clinic, has explored this tension directionally, suggesting that the relationship between BP lowering and kidney protection in seniors is not linear in the way earlier guidelines assumed. If you are currently taking an ACE inhibitor or an ARB for blood pressure management, it is worth asking your physician specifically whether your current target is being evaluated against your kidney filtration numbers, not only against your blood pressure reading in isolation. Those are two different conversations. Your blood pressure right now may look exactly where it should be while something else is quietly shifting. 2 organ systems named. Both were told to you as systems the medication was protecting. That tension is worth sitting with as we continue. Walter was 73 years old, a retired civil engineer who had spent his career managing the kind of precision that infrastructure demands: load tolerances, pressure differentials, structural stress calculations. He applied the same discipline to his blood pressure. He took his medication at the same time every morning. He logged his readings. His numbers were textbook, consistently sitting at 118/76, exactly where his cardiologist had aimed. For 2 years, his chart reflected perfect control by every standard metric. What his chart did not reflect was the thing his family began noticing. He would lose a word mid-sentence, reach for it, pause, move around it. He began forgetting the names of people he had known for decades. His daughter assumed it was early cognitive decline. His cardiologist saw nothing in the numbers that required attention. It was not until a cardiology consult prompted a recalibration of his BP target, moving it upward, that Walter's verbal recall began, week by week, to return. The symptom his family had accepted as inevitable had a cardiovascular mechanism. What you were told was perfect control may have been the source of the symptom you stopped mentioning because no one had a name for it. This is where that open question from the beginning of this video finds its answer. For adults over 70, research now suggests that systolic targets closer to 130 to 140 may support better outcomes across cardiovascular, renal, and cognitive systems than the aggressive sub-120 targets derived from data on younger populations. That is not a number pulled from alternative medicine. It is a directional finding emerging from reanalyses of major trials, including the SPRINT and SPRINT-MIND data, where subgroup outcomes in older adults showed results that the headline numbers did not foreground. Your blood pressure right now may be hitting a target that was never calibrated for who you are physiologically at this age. Cerebral autoregulation, the brain's mechanism for maintaining stable blood flow across a range of systemic pressures, shifts its lower operating threshold upward as vessels stiffen with age. What preserves adequate cerebral perfusion at 120/80 in a 45-year-old brain may produce relative underperfusion in a 73-year-old whose autoregulatory floor has risen along with arterial stiffness. The brain is not failing. It is being underserved by a pressure that looks safe on paper. Cognitive changes in seniors on blood pressure medication deserve a direct conversation with a physician, not reassurance that they are a normal feature of aging. That conversation belongs on a chart. There is a fourth mechanism. It does not operate in the brain or the kidneys. It operates in the chest, in the muscle that was the original reason the medication was prescribed. I want to tell you something directly before we get there. 12 years ago, I was reviewing the chart of a post-surgical patient, a 71-year-old man who had come through a coronary artery procedure without complications. His recovery was technically clean, but 3 weeks out, his fatigue was not resolving the way the surgical trajectory predicted. We kept attributing it to the procedure. One afternoon, I looked more carefully at his resting heart rate. It was sitting at 49. He had been on a standard beta blocker dose prescribed before surgery, and no one had revisited that dose in the context of his post-operative physiology. I adjusted the conversation with his cardiologist. Within 2 weeks, he described feeling like he had rejoined his own life. That was the moment I stopped treating fatigue in seniors as a default aging complaint and started treating it as a cardiovascular signal that deserved investigation. The exhaustion that seniors on beta blockers describe as simply feeling slower gets attributed to age with a consistency that is almost universal. It almost never gets investigated as a medication effect operating exactly as intended, but at a dose calibrated for a cardiovascular system 15 years younger. Beta blockers work by reducing the heart's rate and force of contraction. In younger hearts with strong contractile reserve, that reduction is well tolerated. The system has margin to absorb it. After 60, baseline cardiac output is already on a natural decline. The same beta blocker dose that managed a 58-year-old's blood pressure without functional consequence may be suppressing an older heart's output below the threshold needed for sustained daily energy, for the walk to the mailbox, the afternoon without needing to sit down, the mental clarity that used to come easily. The fatigue is not imaginary. It is hemodynamic. It has a mechanism. The European Society of Cardiology has published position papers examining beta blocker dosing in elderly patients, with a growing body of literature pointing toward the importance of age-adjusted dosing conversations, not as a fringe position, but as an emerging clinical priority. Critically important to understand, a beta blocker should never be discontinued or adjusted without direct medical supervision. The cardiac risks of abrupt discontinuation are serious and real. What belongs in your next appointment is a conversation, not a unilateral decision. There is one more mechanism remaining. It does not target a single organ. It targets the morning itself, the specific 90-minute window when your cardiovascular risk is at its daily peak and when your medication may have the least concentration in your system of any moment in the day. Most once-daily blood pressure medications reach their lowest plasma concentration in the early morning hours. The medication taken the night before, or even the previous morning, is at trough, its weakest point. precisely when your body is executing its daily cortisol surge, activating the sympathetic nervous system and driving a natural spike in systolic blood pressure that occurs in the first 90 minutes after waking. In seniors with stiffer arteries and reduced vascular compliance, that morning surge is amplified beyond what younger cardiovascular systems experience. The window of highest daily cardiovascular risk and the window of lowest medication coverage are, for many seniors, the same window. Research in chronopharmacology, the discipline examining how medication timing interacts with the body's circadian rhythms, suggests that when antihypertensive medications are taken may meaningfully affect morning blood pressure control independently of the dose itself. The Hygeia chronotherapy trial and subsequent chronopharmacology research have generated significant clinical interest in individualized timing approaches, with particular relevance for seniors whose morning surge is most pronounced. Medication timing adjustments must always be made in consultation with the prescribing physician. Timing interacts differently across drug classes, and individual evaluation is essential. The question has shifted. It is no longer whether standard blood pressure management may be working against you. 5 mechanisms have just answered that. The question now is what you say to your doctor at the next appointment. Calmly, specifically, with information your doctor may actually find valuable. That is exactly where we are going next. Something worth acknowledging before we discuss what to do. The belief that a physician who completed a decade of medical training and has managed hundreds of hypertensive patients must know precisely what blood pressure target is right for a specific 70-year-old is not an unreasonable belief. It is the belief most of us were raised to hold, and it deserves to be taken seriously before it is complicated. The guidelines that established 130/80 as the standard target were derived from landmark trials, the SPRINT trial, successive JNC guidelines, AHA consensus documents, that represented the best available evidence at the time they were written. The physicians trained on those guidelines were not taught to question them. They were taught to apply them with consistency, because consistent application of evidence-based guidelines is, by design, what prevents worse outcomes across a population. Following a guideline with fidelity is not a failure of care. It is the system functioning exactly as it was constructed. What the system was not constructed to account for is its own latency. Research takes years to complete. Reanalyses take more years. Clinical guidelines take more years still to be updated and disseminated, integrated into continuing education, and translated into the individual appointment where your blood pressure reading is entered into a chart. The physician sitting across from you in a 15-minute visit may not yet have had cause to examine the emerging literature on age-appropriate BP targets in adults over 70. Not because the literature does not exist, not because they do not care about your outcomes, but because no institutional mechanism has flagged it as urgent enough to reach them between patient loads. I have watched this gap operate from the surgical side for more than 2 decades. It is a structural gap, not a personal failure. The anger that this information may have generated is understandable, but the most useful place to direct it is not toward the individual physician who followed what they were taught. It is toward becoming the patient in that appointment who asks a specific, informed question and makes it impossible for that gap to stay closed. What comes next is exactly how to do that. You came into this video as a patient. You are leaving it as someone who now holds specific cardiovascular knowledge that most people managing blood pressure after 60 were never offered. That is not a small thing. And it is the only thing that actually changes what happens inside a 15-minute appointment. The first step is something you can do tonight. Write down the exact systolic target your doctor has given you. Beside it, write the names of your current blood pressure medications and what category each belongs to, whether it is a vessel relaxer, a heart rate reducer, or a fluid reducer. Then write down the 3 symptoms covered in this video: the dizziness that arrives when you stand, the afternoon fatigue that has become your baseline, any cognitive fogginess you have stopped reporting because no one gave it a clinical name. That list is not a complaint. It is the beginning of a different kind of appointment. The second step is one addition to tomorrow's breakfast. Research suggests potassium supports healthy vascular function and may help moderate blood pressure naturally as part of a broader cardiovascular approach. A banana, half an avocado at lunch, a sweet potato with dinner. One change, one meal, working with your cardiovascular system rather than simply suppressing a number on a cuff. This is not a replacement for medication. It is the kind of evidence-based addition that a genuinely informed conversation with your physician can help you build on. The third step belongs at the next appointment itself. Ask your physician directly whether any of your current medications carry orthostatic hypotension risk, the standing blood pressure drop discussed earlier, and whether the timing of your antihypertensive has ever been evaluated for morning surge coverage. Not as a confrontation, as a question from a patient who has done their research and wants their care built around their actual physiology. Research suggests that specific dietary and lifestyle adjustments may meaningfully support blood pressure management alongside medical care, and that the combination, brought openly into a clinical conversation, is where individualized care for your blood pressure right now actually begins. That is an honest, qualified statement. And it is the answer to the question left open at the beginning of this video. Writing that question down tonight and walking into an appointment with it in your hand, that is already the act of someone whose heart is being advocated for properly. Everything covered in this video can be pulled into 5 clear points you carry forward. Blood pressure medication working exactly as prescribed may be creating dangerous drops in standing pressure in seniors whose baroreflex can no longer compensate quickly enough for postural change. Aggressive BP lowering may be placing stress on the very kidney filtration function it was prescribed to protect, in seniors whose renal vasculature requires adequate perfusion pressure to keep functioning. Systolic targets appropriate for middle-aged cardiovascular systems may be reducing blood flow to aging brains whose autoregulatory floor has shifted upward with arterial stiffness. Beta blockers dosed for younger hearts may be suppressing cardiac output below the threshold a senior cardiovascular system needs for daily energy, not as a side effect, but as a direct hemodynamic consequence. And standard medication timing may leave seniors with the least antihypertensive coverage during the 90-minute morning window when cardiovascular event risk is at its highest point of the day. If any of those 5 points connect with something you have personally experienced, I want to hear about it. Leave a comment below with what systolic target your doctor has currently given you, and share whether you plan to bring any of these 5 points into your next appointment. Not as a yes or no, but as your actual experience, in your own words. What you share in this community matters to every other senior watching this video and wondering whether what they feel is normal. If you know someone who takes a blood pressure pill every single morning and has never once asked whether the target on their prescription was designed for the cardiovascular system they have at this age, send this to them. Not as an alarm, as information that belongs with them. In the next video on this channel, I am going to cover 3 natural compounds that research suggests may support healthy blood pressure in seniors, including one that almost never comes up in a routine cardiology appointment and that may work through a mechanism most people have never heard named. Make sure you are subscribed so you do not miss it. Taking care of a heart that has been working without pause for 6, 7, 8 decades is an act of genuine respect for everything it has carried. Writing one specific question on a piece of paper tonight and bringing it to your next appointment is not a small act. It is an informed patient asking for care that is actually built around them. That question deserves to be asked. Your heart has earned that conversation.